Hello, good morning, everybody. We are speaking from Humanitas Castelli, and we are operating a case of persistent idiopathic macular hole. Left eye, the male is 62 years old. The visual acuity is counting finger 3 meters, so 20 over 400. The history of this patient was a phaco combined with vitrectomy and inverted ILM flap. And after that was done also a free flap, but the macular hole is still open. We were thinking about to do something different according to the literature. So we are presenting a case of autologous retinal transplant. We are operating with a dark machine, 25 gauge. As you can see here, the infusion is outside the trocar, not inside the trocar. That's important because allows us to have a high flow infusion, because there's not the reduction of the trocar that's placed inside, but because of the flow is dependent to the radius of the tube, so we can gain higher flow. That means that we can keep the infusion lower, but at the same time, if we need to have a better flow in order to avoid the hemorrhage, we can increase the pressure. So we are placing now the 3 trocars, and we will start then with the vitrectomy. Can you give me the light, please? I always start with an anterior vitrectomy, doing also a capsulotomy. And the reason is to do that is also to interrupt the anterior hyaloid. That's good. So, when just speaking about the autologous retinal transplant, there are just few cases published from the literature. The autologous retinal transplant has it has been done for persistent myopic macular hole, for persistent idiopathic macular hole, also for chronic retinal detachment with the PVR associated with macular hole, and also has been also tried for exudative age-related macular degeneration in presence of atrophy, macular atrophy, and also macular hole formation. So the autologous retinal transplant is placed epi-intraretinally, okay, whereas only in the chronic retinal detachment with big macular hole has been placed under the retina. The same kind of approach subretinally, has been done also, has been published also by Rizzo, but using not retina but autologous amniotic membrane. Okay, so today we are trying with the retinal transplant. So far we didn't have still have approval for use of intraocular amniotic membrane. So the first point is the best site of harvesting the retinal tissue according to the site and the size, okay, according to the presence of photoreceptors to transplant. So, and we place, as you can see, just up to the above to the arcade, to the superior arcade. Because we know that within the 30 degree, between 25 and 40 degree, there is still a higher concentration of photoreceptors, so rods, okay. This is the point to do that, not far in periphery, so above the 60 degrees, but between the 25 and 40 degrees. Okay, so I'm doing now the diathermy. I'm not inducing any kind of um, retinal detachment. Just a second. Can you clean the lens, please? I'm now putting just a bit of perfluorocarbon liquid. Okay, in order to decrease also the hemorrhage and to see exactly, um, the retinal transplant. So, as I was saying, I'm not inducing any retinal detachment. We don't need really. I will just cut around inside, let's say, the diathermy, and then I will take the graft over the macular hole. These are vertical scissors, 25. scissors have like a big scissors, okay, that can cut. As you can see, a bit of blood, but I can see well because of the presence of perfluorocarbon liquid. I need to cut all around. So the cut is almost completed. Okay, that's very good. Okay, okay, now I'm getting the graft and placing over the macula. You see, I was not dragging. Now it's sticky attached to the forceps. As you can see, I was not dragging because we need to keep in mind that we have the photoreceptor, so we cannot really drag over the macula under PFCL, but I prefer to lift it up and then place right on the fovea. And this is a perfluorocarbon liquid, this is on it, okay? So I'm trying to cover all the area. It has to be a little bit more, not much, little bit more than the macula hole itself, because there's a bit of shrinking later on. The amniotic membrane you need to place the subretinally, okay? So you need to induce a bit of detachment around. In this case, I mean, you really don't need it. So now I will now carry on with the laser all around the retinotomy. under perforated carbon liquid, of course. And then the next step is to perform the removal of perforated carbon liquid. This is another issue to keep in mind. Let me finish a bit. We are now removing perforated carbon liquid. Air is coming in. The point now, in order to avoid the displacement of the graft, the best things to do is to remove all the water that is present inside the eye. So what we can do, we can now remove perforated carbon liquid, but we can leave a bubble around. Now there is air, perforated carbon liquid. Have you seen that I was removing fluid? Okay, and then if you have seen, there is a change of the meniscus of the perforated carbon liquid when is in direct contact with air instead with water, because we know that perforated carbon liquid against water has an interfacial tension of 50 millinewton meters. It's different with air. So when you remove all the fluid, okay, you see that change the meniscus becomes more flat. Okay, so the meniscus between air and the perforated carbon liquid is more flat. So as you can see here, now there is not much water inside. So we are going straight from perforated carbon liquid to the air. So the reason of all these things is we don't want that the graft will be moved by the water, has to be right on the macular hole. So now we are trying to remove everything, so also the perforated carbon liquid, and the air is coming to replace the perforated carbon liquid, and then we will ask the patient to stay face down. Otherwise, what you can do, the direct oil perforated carbon liquid exchange, but in this case then we need to ask the patient again to do another surgery, and the patient has already three surgery, done three surgery. So we are going then to tamponade with gas. Okay, last steps. So perfluorocarbon liquid, and then we don't have to be afraid to leave perfluorocarbon liquid under the graft, because perfluorocarbon liquid has a high interfacial tension, and so comes in one bubble. So when we remove perfluorocarbon liquid, will be removed all of the perfluorocarbon liquid that could be under the retina of the macular hole, of course. Of course, you know, it's different when we have a perfluorocarbon liquid under the retina that is going in a small bubble from the periphery. But in this case, you know, the macular hole, the the bubble of perfluorocarbon liquid is just one and is covering everything. So, you know, will come out in one bubble when we remove. So that's it. We will check again. So thank you very much, and we'll see for next surgery.